Regenix Group, an endocrinologist and industry leader who will speak on pre-diabetes and early metabolic intervention to preserve beta cells in clinical practice. Please put your hands together and welcome Dr. R. Balaji.
Good evening, everyone. So I think, first of all, I would like to thank Economic Times and the organizers, I think, for giving me this opportunity to speak here today. I think the last session was very informative, and I think the session was about preventive health, which is in what similar lines I'll be talking about now. So I think the topic that has been given to me is about pre-diabetes, which is something that as doctors ourselves we miss a lot, and it is a window of opportunity for us. So I would like to talk about this. So whatever I'm going to say today, it is on a single idea, okay? So here what I want to tell is pre-diabetes, it is a window, okay? It is a window of opportunity for us. And it is a point at which the trajectory, either you can change the direction. If you see, we all talk about diseases and treatment of diseases, but at the end of the day, most of the diseases are irreversible and there's no cure, especially when we come to diabetes, there's no cure, there's more control. But here, when we talk about pre-diabetes, here we can change the trajectory where we can change the direction. And we pour enormous effort into managing diabetes, but here we keep forgetting the easy way out, which is the prevention, which is the pre-diabetes. So there is a warning sign. So when there is a warning sign, if we can change the trajectory, then we can manage this in a better way. So if you see, there are two numbers in front of you. So what do you see there? Like two really alarming numbers. As you know, India is the diabetes capital of the world. And I don't think that's a proud thing to talk about. But if you see, we have 101 million diabetics living in India as of now. What is even bigger is the pre-diabetes patients. If you see, this is according to the ICMR Indian diabetic data. We have 136 million diabetics living in India, okay? So this is something that we need to look at. Okay, so here we see in India the pre-diabetes numbers outnumbers the diabetes numbers. So what we see here is an opportunity, okay? So the opportunity for prevention. And if you see here, see all these patients, they have no idea that they are pre-diabetic, okay? And here every 136 million people is a decision point for you as doctors. So because either one of you will find them or they will not be diagnosed at all. So it is up to you to find these patients, the pre-diabetics in India, which is alarmingly increasing in numbers. So coming to pre-diabetes, so pre-diabetes is a intermittent hyperglycemia. Hyperglycemia means the increase in sugar levels in the blood. So it is not always high, it comes and goes, but that is a problem. So here if you see, it is a metabolic warning, okay? The body is warning you that it is not okay. So it is the pre-diabetes stage. It is because of a lot of factors. If you see, it is your lifestyle, it is the way you live, the stress and all of it. It is a lot of factors which eventually leads to, and it is also your genetic predisposition, which leads to pre-diabetes followed by diabetes, which is almost inevitable. So here you have a decision to make, okay? So how do we diagnose pre-diabetes? So we've got two methods here. One is you look at impaired fasting glucose, okay? So whenever, before you eat breakfast, so you are in a fasting state, and you can check your blood sugar levels at this time, and this will give you your sugar levels. And the second way is by doing an impaired glucose tolerance. So here what happens is that you give the patient 75 grams of glucose, and then you repeat the blood sugar, and you use the blood sugar levels here again to diagnose the patient. So these are two ways by which you can diagnose the patients. Okay, next is how do we diagnose it? So it's quite very simple. It's an inexpensive way to do it. You just check the blood sugar levels. I think almost all patients or people nowadays have a blood glucometer by which you can prick your skin, take a small sample of blood and test it at your house. So, but diagnosing it is not the hard part, okay? So, according to ADA, so we can diagnose it using the fasting blood glucose. So, either before eating, you take the blood sugar levels, or you can do it with the glucose tolerance test, where after eating, you give 75 grams of glucose and then you check it. Or you can also do HbA1c, okay? So, HbA1c between 5.7 and 6.4%, so which is one of the commonly used methods to diagnose prediabetes. So here, if you see, the hard part is not diagnosing. It is not the cost. So we saw in the previous meeting that cost is another factor, but here it is not the cost, it is not the technique, it is about the accessibility. It is about testing the patients, okay? See, so it is about testing all patients which come to your clinic, because if you see, the incidence and prevalence of prediabetes is increasing in India. So this is the slide I would most like you to remember. So Indians carry what is called as the thin fat phenotype. If you see the Western people, they are like their BMI is high and they are fat throughout the body. But if you see Indians, they will have normal BMI, but still they have something called as apple obesity. Okay, well, it is called as centripetal obesity, which is typical of Indians. Okay. So we have Indians compared to the Western people, we have higher body fat and greater insulin resistance at a lower BMI. Even though our BMI is normal, we still have insulin resistance. And this is something that as doctors we miss out. So this is something that we need to look at, and the consequence is measurable. Okay. So here, what is the difference between the Western population and the Indian population? So if you see, majority of the studies that has been done has been on the Western people, but it has not been done on the Indian people. And in Indians, what happens is that prediabetes occurs a decade earlier. Imagine the timeline, okay? It is about 10 years earlier than in the Western population. So here you need to take note, you need to test patients at a much earlier stage. Okay. So prediabetes is not a stable state, okay? If the patients are left alone, what happens? About 70% of these patients will go on to develop type 2 diabetes, okay? So each year, about 5 to 10% of them cross over. And sit with that annual figure for a moment. Imagine in your clinic, you have hundreds of patients, and every year, 5 to 10% of these patients are becoming diabetic. And this is the whole point of this evening. Progression is a trajectory, it is not a verdict. So trajectories can be bent and the window is real. It does not stay open indefinitely. So you need to act. So here is what surprises a great many clinicians. So the harm starts before the label. Before you diagnose the patient, the harm has already started. In terms of heart, the cholesterol has started building up. In terms of the nerves, the nerve damage has started. So you need to pick up these patients as early as you can. So in terms of kidneys, the damage is already done. So when the patients come to you, so the damage is already done. So when you treat patients with prediabetes, so you're not only preventing diabetes, you're also doing cardiovascular prevention. You're also protecting the kidneys, the nerves. So there's a lot at stake here. So it means that the patient in front of you with a fasting sugar of 112 is not somebody that you need to see next year. it is not your future patient, but it is your current patient, which needs to be seen immediately. So what do we do? So screen every adult from the age of 30 to 35. So these are the numbers. And earlier, in the presence, if patients are younger than that, if they have any risk factors, as you see on the screen here, so overweight or central obesity, as I told you, which is very, very specific for Indians, central obesity, and family history of diabetes, hypertension, or dyslipidemia, which means the cholesterol is high, and any history of previous diabetes during pregnancy, or as very common in women nowadays because of lifestyle, PCOD, polycystic ovarian disease, and physical inactivity. These are all very common, and all of these, if these risk factors are present irrespective of age, you will screen them for pre-diabetes. And it is very, very inexpensive. You don't need to do even a lab test. You can, these patients can be screened in the clinic. So the Indian Diabetes Risk Score is free, and it takes only under a minute to do it. And it turns any clinical visit or any complaints into a screening opportunity for you, okay? So this is the evidence that should change practice. The US Diabetes Prevention Program, a landmark randomized clinical trial. So they have done two things. Number one, they have done intensive lifestyle modification, diet, exercise. And the other one, they have given metformin, which is the drug which we usually give to patients once they are diagnosed with diabetes. If you see here, look at the two numbers. The reduction with the lifestyle is almost double compared to metformin. So it is not marginally. So here you have to focus, it is almost twice the number, 30% and 60%. So it is the level 1 evidence, and it is the most powerful tool for a clinician. So here you can see that prevention works. We have known that it works for over 2 decades. So what we have not done? We have not delivered it at scale. So do our patients follow this? No. So whenever I tell my patients lifestyle modification, they are like, doctor, can you not start me with the tablets immediately? It is the easier way. Everyone wants to take the easy way out. But mark my words, so what is more important is lifestyle management rather than clinical intervention. So here, this is what you can tell, this is not only for doctors. It can be your neighbor, it can be your relative, your mom, dad, it can be anyone. So these are the simple steps that they have to follow, and this is based on evidence. This actually works. Number one, you can see 5 to 7% body loss. I'm not asking patients to lose 30 kgs, 40 kgs. It is only, let's say it's a 100 kg adult, only 5 to 7 kgs. What happens? It reduces the risk of insulin resistance. Second, 150 minutes a week of moderate brisk activity. Just brisk walking is fine. 150 minutes a week, it can be broken up into any time. And diet quality, okay? It is about high rich fiber diet, fewer refined carbohydrates, and a lower glucose load. Not too many sweets and all of that. And fourth, good sleep. 7 to 8 hours of sleep, because again, poor sleep worsens insulin resistance. And also, the fifth one, the most important one, is stress. Again, what happens? Stress releases a hormone called cortisol. This, in turn, causes insulin resistance. So these are 5 simple steps that anyone can follow today, starting today, to prevent the risk of diabetes. So lifestyle always comes first, okay. But per ADA guidance, consider metformin. Okay. So we can give metformin as the first line therapy even in pre-diabetes patients. I'm not talking about diabetes here. So as per American Association guidelines, we can give metformin in patients where it is indicated, and particularly in patients who are obese with a BMI of 35 or above, in patients under 60, in women with pregnancy-related diabetes previously, or where the HbA1c is high. So these are all some of the principles where you can start metformin. Again, this is for prevention. I'm not talking about treatment here, I'm talking about prevention. So we have two options. One is lifestyle management, as I told in the previous slide, or you can actually start these patients on metformin. So here is a simple scalable pathway for the patients who come and see you, mainly for doctors. You screen and then you diagnose. You stratify the patient by risk, as I've told you, depending on the age, whether they have had diabetes during pregnancy before, and all of that. And then you intervene, leading with lifestyle and monitor and escalating when what the numbers tell you. So the power is entirely into your routine workflow, so that it happens without anybody having to remember it, okay? So every visit is a screening opportunity for you, and every early detection is quite literally a life changed. So where does the change begin? It is not only in the hospital, it is not only in the clinic, it is outside. You know, it's where the patients are. So we have to step outside the consulting room. So opportunistic screening at every clinical encounter so that nobody is missed. So your community, your workplace, everywhere, camps can be conducted to screen patients for pre-diabetes. It is very, very easy. So taking the test to where the people actually are. There's a lot of digital tools which have come up, apps, SMS reminders, teleconsultations. So because prevention lives or dies on follow-up. You can do it today, but it has to be followed up throughout, not only on the first visit. And above all, a prevention-first culture is what we need to follow. Rather than moving on to treatment, start with prevention. Because catching pre-diabetes early is among the highest value interventions that you can do in diabetes care today. So 3 takeaways I would like for you to take away from this presentation is that, number 1, pre-diabetes is very, very common, commoner than you think. You might have it today. I would urge you to go check it out. So it is silent, you never know you have pre-diabetes, and it is largely reversible. That's the most important thing. It can be reversed. 136 million Indians, most of them are undiagnosed. And a metabolic window that is open, but it will not stay open forever. So you need to act now. Number 2 is screen widely. So act early and lead with lifestyle intervention. Rather than with medication, lead with the lifestyle intervention. And the third one, the line I would like you to carry out of this, is that the best time to treat diabetes is that you treat it before it begins. Not rather than the patient is diagnosed, then it becomes irreversible. There's a lot of damage. You start screening patients and you treat them before it becomes reversible. So prevention begins with the next patient that walks into your room. Thank you very much for the opportunity.